It's a really exciting time that we're about to embark, or have been embarking on since the drugs became available, the direct-acting antivirals, since the 1st of March. Today my job is to talk about the current landscape, and basically for me it's just time to eliminate, and we need to be just getting on with this job. I have a number of disclosures I should acknowledge, in particular that I do receive funding from Gilead Sciences, AbbVie and BMS for investigator-initiated research projects. So what I'm going to do today is this morning is just sort of set the scene. I'm not going to go into details because different people are going to be speaking about different things, but I'm basically going to give a brief overview of the epi, though Robert's spoken a little bit about it, talk about elimination. I'm going to talk about the WHO elimination targets, but I think we should just keep in mind that the Victorian government will be releasing strategies and targets for Victoria in a couple of days' time, and they will be very similar, I suspect. Why hepatitis C elimination is possible, why I actually think we can do this, and that we should not be afraid. The costs, restricted treatment, why the issue of diagnosis, and then also the importance of prevention. And then I'm just going to give a snapshot of what's going on, not just in Australia. We're not alone in this attempting to eliminate hepatitis C. Give a snapshot of a couple of countries and essentially of where we should go. So, as Robert said, hepatitis C is a major problem. The estimates vary between 110 to 130 million people are infected by it globally. And the big issue is that people with chronic hepatitis C are susceptible to liver-related deaths and liver cancer, and these deaths are increasing. And they will continue to increase because as the bulk of the epidemic moves along, unless something is done. Basically, an estimated 800 million deaths, though it varies, and it will continue to increase over the next 10, 15 years in particular, and have an enormous cost to the community. Hepatitis C is distributed globally. It does vary, but there is no country where it is not an issue. And there is no country, at least where we have data, where it's not an issue. And that's one of the biggest problems globally, is in many resource-limited countries we do not have quality data on affected populations. So when people talk about it not being present, often it's not being measured. And that's a really big issue that we need to think about. For Australia, we're in a really good position in terms of our public health systems to have a better and clearer understanding of it. We're not perfect about it, but globally it's an issue to know what's going on in the distribution. One of the biggest drivers, and certainly in Australia, is basically of disease transmission, is amongst people who inject drugs. And again, globally it's a problem. You will hear about some countries, it's like what happened in the past with HIV, where people say, oh, well, we won't have a problem with HIV because we don't have gay men in our country. And it's those kind of things. We don't have a problem with hepatitis C because we don't have people who inject drugs in our country. You know, I've just got back from being in Kenya, where basically the hepatitis C prevalence in people who inject drugs in Mombasa is over 60%, and there's a high proportion of the population there. Previously, we were hearing Kenya doesn't have hepatitis C. So this is a problem globally. But it's also a problem for Australia, where our driver of disease for hepatitis C in particular is people who inject drugs, and we need to be really thinking about how we manage that. Another area which is of issue globally and also an issue for Australia is co-infection. So people who are HIV positive, in particular gay and bisexual men, are at risk of hepatitis. So HIV positive gay and bisexual men are at risk of hepatitis C. And so this is another issue that we need to be thinking about as we try and work on strategies to eliminate transmission, stop people from getting sick from it. And the big issue with HIV, obviously, is if you are hepatitis C co-infected, your disease progression is faster. So again, globally it's an issue, in particular in Australia it's an issue. The two big drivers and things that we really need to concentrate on will be people who inject drugs, gay and bisexual men, and then other vulnerable populations where we basically have limited health service access. The Sustainable Development Goals were passed late last year, so they followed on from the Millennium Development Goals previously. And pleasingly, for the first time, hepatitis was mentioned. As I say to people, I would have loved to have had it that we basically by 2030 end the epidemics of AIDS, tuberculosis and malaria and viral hepatitis. Didn't quite get a Guernsey on the elimination stakes. There's a lot of politics in the global, these kind of things, and the SDGs, but at least it got mentioned as combat. Now, I take combat as being eliminate, and so I think that we should just basically go, it's just a minor issue of phrasing. So basically we're going to combat hepatitis, as well as these other key issues. The other really important thing about the Sustainable Development Goals was the clear acknowledgement of the importance of equity and universal access. And I think that this is a really important thing when we begin to talk about diseases where stigma is attached to them. That there are many people who will not get the care, the treatment, the testing, whatever it is that they require because of issues of equity and access. And basically the Sustainable Development Goals say we need to be aiming for universal coverage. And I think this is something we need to keep in mind, both within Australia but also in our work globally. The World Health Organization, in response to the Sustainable Development Goals, basically has released elimination targets. They talked about a world where viral hepatitis transmission is stopped and everyone living with hepatitis has access to safe, affordable and effective care and treatment. Basically to eliminate hepatitis, viral hepatitis, both B and C, but we're talking about C predominantly today, as major public health global threats. Now the word eliminate for a epidemiologist, if I wanted to get pedantic about it, is we're actually not going to eliminate it from a technical hepatitis epidemiology point of view. That's kind of hard, and in fact what we're going to be doing is really combating. We're going to be eliminating it as a public health threat. So in essence, the impact of this disease globally goes down markedly, as opposed to a formal elimination where it will be no more disease anywhere, because that's incredibly difficult to do with certain types of diseases, particularly if we don't have a vaccine. We may be able to eliminate it into the future, and Heidi, Drummer, will be speaking about today, sort of new things and exciting things coming along with vaccines, but probably not by 2030 because of the chronic nature of the disease. But we can certainly do it as a public health threat. We can stop the deaths. The WHO targets are really ambitious, but I don't think beyond us. And as a person who was involved in a lot of the modelling and the setting of these targets, I think they should be something that we should be not being fearful of, but actually saying, why are we waiting so long? And that will be one of my challenges, I think, for people today. Essentially, there's two key targets, is to stop deaths related to hepatitis C and basically reduce these deaths by 65% globally. I think Australia can do much better than that, and we should be aiming to do much better than that by 2030. And the other key target is to reduce new infections really by 90% by 2030. And that's going to be achieved by basically making sure people are diagnosed, making sure that people have access to treatment, and also, as Louise mentioned, harm reduction will remain a central pillar to this. We basically need to make sure that people have access to clean needles and syringes and opiate substitution therapy, something that doesn't happen in many, many places globally. Why do we think this is possible? And as I say to people, the reason we think this is truly possible is based in part initially on work done by Peter Vickerman, Natasha Martin and others from the Bristol group. They developed a model which simply said, if we treat, we don't have to treat everybody immediately, but if we treat, depending on your background prevalence and what's driving your infection, and they focused on people who injected drugs, but this same applies in other areas. Basically, 5 or 10 or 40 people per 1,000 every year, we can substantially reduce the background prevalence of this infection. So we don't have to treat everybody today. The faster we treat, the more we treat, and importantly, the more we treat of people who are driving the infection through no fault of their own because they're not having access to clean needles and syringes or opiate substitution therapy. Basically, if we offer them treatment, we can impact on prevalence and begin to reduce prevalence and incidence. Modelling that we've done at the Burnet basically took the work of Peter and Natasha and we said, okay, well, how are we going to go with these WHO elimination targets? And what we showed was something that I think is really important for people to understand. If we just treated people with severe liver disease and thought of this as it belongs in the liver, it's a liver disease, and only treated people who had significant liver disease, we can reduce the deaths related to hepatitis C here, right down. So this is people with severe liver disease. But the prevalence, the proportion of people who remain infected with hepatitis C stays really high. But in Australia in particular, so this was based on Australian data but can be extrapolated elsewhere, if we treat everybody, not only do we substantially reduce the deaths related to hepatitis C, but also we reduce the prevalence related to hepatitis C. And this is treating as few people as about 5,000 people who inject drugs every year, and about, for the first 5 years, around 5,000 people with significant liver disease. So this modelling was done by Nick Scott in our group. But essentially it says this is entirely doable. And if we look, and Greg I'm sure will be talking about it, Greg Dorr will be talking about treatment rollout at the moment. But already in Australia, that number of scripts have been written. A lot more than that number of scripts will be written by within a year. So this is not an impossible task. Our challenge will be, and we will in part talk about it today, is to ensure that we don't treat 20,000 people, but they are all people down here, but it's important we do, but that we basically include people who inject drugs in that. Because if we fail to include these vulnerable populations in receiving treatment now, we will not reduce disease prevalence and incidence. So I think that's a really important thing to understand. We are already going to be treating enough people to make elimination possible, and I suspect before 2030. But our challenge will be to make sure that we're treating and not letting key people, and making sure we have quality access to key people, including people who inject drugs in Australia. So why has elimination become achievable? Essentially because treatment with direct-acting antivirals without pegylated interferon and ribavirin. For those people in the audience who have been treated with pegylated interferon and ribavirin, they will well know the significant side effects associated with it. As a clinician who's treated people with it, it was like giving people ongoing low-level to high-level poisoning for 24 to 48 weeks. But it was, you're weighing up, what was a better thing to be doing. So it was important to treat some people, but I think we have to recognise it was horrible. And that these new treatments are not horrible. They have minimal side. It's not like they're not without some side effects, but they have minimal side effects. They have high efficacy, over 95% cure for the vast majority and the new ones to come, and also just 12 weeks. But it will only be possible that we can eliminate using these fantastic new medications if we have equity of access. It will be a key thing that we must be striving for in the next month, 6 months, 12 months, 5 years. Equity of access, not just for Australia, where we're in this really good position, and others will speak about that, where basically the government has allowed these drugs to be PBS listed and access for all. That's not the situation globally, where many, many people are missing out on treatment. And I think it's really important that we as Australians don't go, that's nice, we've got what we needed, and we have to make sure that we remain really clear voices within Australia, but also globally, about the importance of pricing, and that the cost of these medications need to come down and be made affordable for everybody globally. I do not think we should be forgetting what's happening globally. The drugs can be significantly cheaper. They are already becoming significantly cheaper than that $1,000 a pill price initially sort of touted when basically Sofosbuvir first came out. And I think we have to be really working that we have this happen. Because there are many people in many places, and this is work by Greg and others, basically showing that in places like the United States, a country where we'd say, look, wealthy country, there should be equity in access to these treatments. Many people are missing out because of a history of injecting drug use. This is happening globally, where many people are missing out because of a history of injecting drug use, or because of the prices of the drugs, or a combination of the two. We should not forget the significant stigma and discrimination that goes on in health services, and we have to have this change. In countries where the epidemic is driven by people who inject drugs, such as Australia, as Louise mentioned, it's really important that we maintain high-quality harm reduction. If we just treat and we do not have high-quality harm reduction accompanying that, we will simply have reinfection occurring again and again and again. And until we have access to high-quality vaccines, but even then, this will happen again and again. And the models clearly show that. So we should not forget that this needs to be made available to all. People often talk about harm reduction and the evidence for harm reduction, but there is clear evidence that opiate substitution therapy does reduce hepatitis C incidence, and high-level needle and syringe program coverage accompanying opiate substitution therapy is highly effective. So there is evidence base for this, and it is highly cost-effective as well. But what we know is that there are many, many countries globally that do not have this, and we again, rather than just thinking Australia's got some of these things, we still don't, in my view, have the coverage that we require, but that Australia has these things. We have to also be advocating globally that this happens if we're going to go for the global elimination of hepatitis C. Many countries do not have opiate substitution therapy. To me, I've got to say, is one of the most cheap, effective, affordable therapies. I often do not follow the logic of why OST is not available everywhere, to me, except to do with stigma and discrimination. So I think it's, again, a really important thing that we have to be talking about. We also need to increase the number of people who are being tested. Essentially, you cannot go on treatment if you don't know that you're infected. So it's a really important thing that we do both within Australia and, again, encourage globally. In Australia, high proportions of people have been tested for hepatitis C. We think it's between 80 to 85% have had an antibody test. So that's good, but that still means that there are people who are not being tested. More importantly, work by Ben Cowie and others in his group with some modelling essentially has shown, though, that of those who have been initially tested at some stage in the past, only 50% know whether or not they've got the virus present in their blood. So in Australia, one of the really important things is for us to reinvigorate people who have been previously tested for hepatitis C, found out that they were positive, but thought there were no really good options for them, that they need to come back into the system, that they basically they need that test confirmed, but in particular they need an RNA test to say the virus is still in the blood and be treated. So we're doing well, but not as well as we would like to think if you think 50% of people actually don't know whether they've got the virus in their blood. Globally, there are many countries where we're doing really, really poorly. And again, it's really important that work is done to increase people's ability to be screened for hepatitis C. The tests are too expensive for most countries globally. They're either too expensive in the sense that they don't have the equipment in the labs, the big machines to do it, or it's just too expensive in terms of practical limitations of being 3 days away from a health service. So basically for me to go in, to travel to that service to get my test is just a logistic impossibility. We need cheap and affordable, which we've got in terms of antibody tests for hepatitis C, but we also need cheap and affordable point-of-care RNA tests for hepatitis C. The World Health Organisation will be releasing global guidelines soon in regard to hepatitis, viral hepatitis testing. And one of the things that those guidelines is really focused on is weighing up the balance of how many tests you need to do to make sure it's a perfect test, as opposed to actually access to tests and equity of testing. So single tests, rapid tests, finger pricks and those things. And so when people are looking at those and saying, look, sort of if I want to get all scientific-y, sort of the positive predictive value of these tests aren't always perfect, but the idea is to say we will compromise a little bit on the sensitivity and specificity of the test if it means that everybody who's at risk has access to testing. So I think that's a really important thing, but I think there's also an enormous amount of work we need to be doing in science here to be developing high-quality point-of-care tests. Even in Australia, we know that we have people not being tested because of basically the time and the number of visits that it requires to go to health services to get that test. And I would be saying we need to be taking innovative steps to be doing in our primary healthcare services, at needle and syringe programs, offering point-of-care tests for hepatitis C. These antibody tests are really high quality. They are fine to be doing that, but at the moment they're not being listed on our MBS. You cannot get them rebated. So we need to be thinking about, why can't I, if I was to go into a needle and syringe program and be picking up clean needles and syringes, be offered an oral point-of-care test for hepatitis C if I've got, and I can get a result within 5 minutes, get some basic counselling and then be organised to have a follow-up point-of-care test RNA, if I'm able to do it at that moment, because these tests will soon be available, or at least booked in to have a blood test in the next 24 hours or so. Why do we've got to work out ways to stop making it so difficult for people to get diagnosed. Because if we want to eliminate, everybody has to get timely diagnosis. And it has to be, for some people who are at risk, that needs to be offered to them over and over again. So how frequently should somebody who injects drugs be offered testing? Well, in my mind, in the same way as we would say for gay males who are at risk of HIV, we would say that many of them should be getting tested every 3 months. Why aren't we setting up systems so that people who inject drugs can have a rapid oral test every 3 months as they come in to pick up needles and syringes? Why are our systems not being well set up to do that? There's no reason why it shouldn't be. Basically, not enough people are being treated overall. So this is a cascade of care which is in either Kirby Institute and others, basically in the National Surveillance Report from last year. We know there has been tremendous drop-off. We also know that this is already beginning to change with the new treatments coming on board in terms of the number of people taking up treatment. But what is less clear is to whether or not that increase in treatment uptake is occurring amongst people who inject drugs in the same proportion as the general population of people who have been previously infected, often in Australia through a history of injecting drug use, but they're not currently injecting. As well as I said, we've got that tremendous drop-off of people who have been diagnosed but actually haven't had the confirmation of the virus in the blood. We need to essentially make it that rather than this cascade going like this, over the next few years we've got to aim for a cascade that goes across there. We know we won't get it perfect, but actually to eliminate hepatitis C as a public health problem, we don't need it to be perfect, we just need it to be a lot better. We also need to get rid of blockages, like how do we actually decide whether somebody has significant liver disease? Of course, if you've got basically, in terms of where treatment should be occurring, these treatments are really simple and the vast majority of treatment needs to be out in the community. People with significant liver disease, yes, probably need to see a specialist. So we need to have simple ways to say, does this person have significant liver disease? If they don't, treatment in community. This can be done by nurse-led models of care, primary care clinicians, a combination of things, but it can be kept in community settings. If somebody has significant liver disease, stage 4, perhaps stage 3, but I would just simply say probably stage 4, refer on. So we need to make sure people have access to things like fibroscans, but why not things like a pre-test, and if it's a really low score, be confident that that person does not have significant fibrosis. We need to look at every blockage that might stop somebody from getting access to treatment and care quickly and say, let's get rid of those. Let's have a look at the system and say it doesn't have to be as difficult as this. We know already people are having delay in their care because of the need for fibroscans or equivalent when we can be making it much simpler. We also have to say that there's, in my view, no one best model of care for anybody. Essentially, there are some people that will need to be in the tertiary setting, but the vast majority of this care should be occurring in community. This can be, as I said, nurse-led models of care. It can be primary care practitioners supervising nurses. In areas with rural and regional Victoria, telehealth in consultation with nurse, in consultation with doctors, whatever we need to basically get care out into the community and making sure that everybody has access to it. We'll go into details, but as you know, many people in this room know, we have models where we've got set up where we've got nurses who are providing treatment for hepatitis, people infected with hepatitis C who have a history of current injecting drug use in vans in the community, where basically the nurse does all of the assessment. They have then a paper check with the clinician, but actually they never see a doctor. Similarly, there's been work done both in New South Wales and in Victoria in the prison system, where again we have it where the whole of the management is done by nurses with overview by clinicians. It doesn't have to be difficult, it is not that difficult, and we have to be constantly working to make this simpler, more cost effective, and making sure that everybody has treatment. Just sort of give you a snapshot of progress towards elimination, what's happening globally. We're not alone in this, and I just want to highlight some of the countries and what they're aiming to achieve. So Georgia, as in the little country near Russia, basically was the first country to declare that they were going to try and eliminate hepatitis C. They had the advantage that Gilead provided them with a whole lot of drug, but what they also had, and the reason why the argument was given by Gilead as to why they provided with this drug for free, is their government had made a commitment. Their government basically said, we're going to have a go at doing this, how cheap will you give us the drug? And they said, are you really going to have a go at doing it? And they said yes, and they said, we'll give it to you for free. There's a lot of arguments about how this should be done, not done, but in essence it was the government commitment. And they have a strategic plan, and they are basically aiming to have this job done by 2020. Yep, 2020, not 2030, 2020. I think it's ambitious. As a person who's had the opportunity to look at the system closely as part of their technical advisory committee, they may not quite make it by 2020, but they're actually going to give it a real whirl. And they're going for 20,000 plus people being treated in a health system which is far less affluent and far less outreaching than ours. So I'm just saying, Georgia's saying 2020, something to keep in mind. Iceland is a very small country, and maybe one could argue they've only got a couple of people that they need to treat. But Iceland's going for 3 years' time, so they're going to beat Georgia. But I would just say, Iceland is a small place. But nonetheless, again, declaration, they're going to do it, and they're well and truly on the way. Again, as somebody that's been asked a couple of times to, consult on this, they were, and what I found was really interesting, because Iceland was apprehensive about actually going for elimination. And I was thinking, there's less than 1,000 people infected. And it was because they'd never treated people who injected drugs. And I would be asked, I won't say the number of times I was directly asked, so you treat people who inject drugs, do you? I say, yes, I do. But you actually treat them. Are you sure that you treat them? Yeah, I'm pretty confident that I've written a few scripts. And it was just this, by senior clinicians there, this lack of confidence in their capacity to do it. And you let your nurses do it. Yes, yep, that's what we're doing as well. They essentially needed reassurance. And it reminded me that a lot of people, despite all of their really, they're great people, great capacity, sometimes just simply need reassurance that this is something that can be done by all of us. They've totally embarked upon it, and I think they'll have it done in the next 2 years, essentially. So it's pretty good fun. Egypt has a far greater challenge. As many people will know, and some may not, basically Egypt has, hepatitis C prevalence in Egypt is one of the highest in the world. And this is because of basically a medically kind of caused epidemic when people were being treated for schistosomiasis. Egypt's epidemic is a combination of a health system which is both the traditional and the non-traditional health, or the formal and the non-formal health systems, ongoing infection, but in essence, a major problem. But they have also declared that they're going to eliminate. So Australia. Our minister, when she announced that drugs are going to be available to everybody, used the E word. I say she used the slightly wrong E word, eradication, but nonetheless she used the word. These drugs were not made available to everybody by mistake. It's not like the government had a brain fade and thought, I just think we'll make drugs, $1 billion worth of drugs available for people over the next umpteen years. We just want to treat people with significant disease. The word eradication, but let's say the word elimination was used. So there was purpose behind this. And we need to, in my view, honour the government's risk and their commitment. They have given us one of the most valuable tools, the envy of the world, in terms of having these treatments available to everybody, and that they can be made available in the community. So we have to make sure we use them properly. Greg will speak to this, but in essence, we're beginning to prescribe, and it's a huge number of people already on treatment. I suspect by the end of the year, and Greg may or may not, I don't know what he'll be saying, but I think we may end up treating within a year more people than we've treated in the last 10 to 15 years in Australia. And the thing is, our challenge is to keep that level of treatment up, and as I said, get it to the right people. To me, one of the ways we have to think about it in terms of elimination, this is work that we've been doing, is basically to think local but act global. It's not an impossible task because hepatitis C doesn't transmit by chance. It is between people. Our work has shown through the TAP study, through our models and through our network study, and we're working on the TAP study, that if we treat somebody and treat their friends, their immediate injecting relationships, we can really have a big impact on the elimination of this virus, and we can have better bang for our buck, so that rather than just treating one person, where we have this higher prevalence, by treating the person and their immediate partners, be it a person they inject drugs with, a person, a gay and bisexual man who they have either used drugs or have sex with. Basically, if we treat in small networks, and also if we basically treat pockets of disease, so if we think about our hotspots, really concentrate on Frankston, really concentrate on key areas where we can basically have really good treatment networks, we can have an enormous impact. So we don't have to have it all done at the one moment, but really working hard in our local areas on our networks. With this in mind, and Joe Doyle will be speaking about it more, a really exciting piece of news, and some of you will have heard about it, is that we were successful in getting a partnership grant in the last round. And in essence, we'll be aiming for the elimination of hepatitis C transmission in people who inject drugs. The partnership grant will run for 5 years. We are basically funded working with the government in partnership with the integrated community health nurses to increase the number of people who will be receiving treatment to about, we're aiming for 1,300 to 1,500 people who inject drugs every year. If we can do that, we can eliminate hepatitis C in Victoria in terms of its transmission by 2030, but in fact, if we go a bit harder, by 2026, we can do it in 10 years. So the partnership grant, basically an NHMRC partnership grant of 1.5 million plus support from Gilead Sciences of a considerable amount of cash in collaboration with Victorian State Health Department and the Department of Justice. Alex Thompson from St Vincent's, who runs the hepatitis program in the prisons, is a senior CI on this as well. But working together, I think researchers, but also other partners, Hepatitis Victoria, Harm Reduction Victoria, and all of the health services have come on board, basically to use the integrated hepatitis C nurses to provide this level of treatment so that we can eliminate in Victoria. So Jo will be speaking about it in more detail, but basically we're about to start eliminating. We've already started with the COEASY study and doing this amongst gay and bisexual men in Victoria. This is work supported by BMS as well, and essentially what we're basically saying is if we treat a sufficient number of gay and bisexual men at high caseload clinics within Victoria using nurse-led models of care with primary care clinicians, as well as some of the work in the tertiary hospitals, we can essentially get hepatitis C prevalence in HIV-positive gay and bisexual men right down within 3 years. So this is a 3-year program, and we think once we've got it down to that level, we've basically just got a small, low background prevalence, and you just then retreat those that get reinfected and obviously encourage harm reduction. So this is a really exciting project as well. Heidi Drummer will be speaking more about it, but there is a need for a hepatitis C vaccine, and there's been a really exciting announcement of a partnership in terms of development of that in the last 24 hours with Heidi and others. But basically, a hepatitis C vaccine is really important. It will be important for Australia because it will stop the issue of reinfection, but it'll be really important globally, particularly in countries where we may struggle to bring in high quality harm reduction. So it's a really exciting development, and Heidi will speak to you about that later. To me, one of our biggest issues will remain, and I put this slide up each time I speak, is stigma and discrimination. The war on drugs has been an absolute failure. It has been an utter failure, and we have to understand that. We have to understand what drove it, and what continues to drive it makes no sense. This is not evidence-based, and I think each time we have an opportunity to speak about this, and I come from an incredibly conservative background, and it took me a long time to get my head around this foolishness of this issue of the war on drugs. We just have to understand it is not evidence-based, it is not helpful. It is simply stigma and discrimination hidden in wrong ways. Really high quality evidence shows this time and time and time again. So we should be not afraid to speak up about this on every opportunity we get. So, in my view, elimination of hepatitis C, we are at a moment in time, as Louise said. We don't often get these moments in time. I've been privileged to get 2. In 1996, prior to that, all of my patients, I remember all the young men I looked after who died of their HIV. And in 1996, we got new drugs, and that stopped happening. And I look after people today that I thought when I first saw them, I came back from having my twins in 1996, my first clinic. I look after a fellow who I thought I was admitting to the hospital to die. I just thought he looked dreadful. I still look after him to this day. He works, he walks his dogs, he lives a really great life. That was 1996 and HIV. This is 2016 and hepatitis C. We have a moment in time, and we should not neglect this moment. I'm going to finish by basically putting up one of my mother's favourite quotes by Theodore Roosevelt about it's not the critic who counts. It's very, very easy for us to be cynical, and it's going to be very easy for us in a couple of years' time to forget the excitement of this moment. But I think we have to be ready to be brave and to speak up and to push really hard and not be afraid that in this attempt to eliminate hepatitis C that we might fail. Because the only reason we will fail is if we basically get a bit cynical about this and take our eye off the ball. So in my view, it's not the critic who counts. It'll be all of us in here who are going to get this job done. And my challenge or my thing will be, let's not wait for 2030. Maybe not. Let's not even wait for 2026. But in Victoria, where we have systems that will enable us to do that, let's be aiming for 2020 and maybe have 2026 as a run over. Thank you very much.